I wanted to start actually just by looking at our first slide, and I'm going to tell you a little bit more about my background. You said the integrity is on, correct? Okay, sorry, I just want to make sure. It used to have a little box up on the top, which it doesn't, so I just think this is, okay, all right, sorry. So childhood cancer is our topic for today. The overall survival rate, when you think about all of the cancers, all the childhood cancers, which are very different than the adult cancers, but when you think about them together, the overall survival rate is greater than 80%, which sounds really great, right? And it is really great. It is a huge difference from back in the last 40 years. So 40 years ago, the overall cancer survival rate for pediatrics was 10%. So it's been a huge jump, which everyone is obviously very excited about, but there's still a lot of work to do because that still means that at least 20% of these kids aren't making it. When we look at the individual diseases, though, that's when you see how there's a really great progression in some as far as survival rates and not in others. For instance, acute lymphoblastic leukemia, your ALL, which is your most common cancer in children. Back in the 60s, there was a 4%. Back in the 40s, actually, you lived 2 to 3 months, and that was it. Back in the 60s, they started giving chemotherapy and trying different things. About 4% of the kids would live, and now it's greater than a 90% cure rate. So 60% of these, the problem, one of the big problems is that 60% of these kids who survive will have late effects. So they will have secondary cancers, they will have muscular problems, they will have potentially infertility, they will have cardiac issues, they'll have issues with lymphedema infection, all kinds of different problems, strictly due to their late effects. And there are about 375,000 adult survivors of cancer in the US now. This slide here shows you so there's about 15,780 new diagnoses per year in the United States, which sounds like a big number. I mean, when you think about 15,000, it sounds like quite a few. But when you think about adult cancers, you think about just breast cancer, and there are millions, right, every year. So when you think about the 15,700, it's really not that many. So it really is, if you want to do something with pediatric cancer, you're a little bit limited in where you can live and where you do that because it's really limited to bigger cities due to the fact that there aren't a ton of patients. So about the 375,000 adult survivors of childhood cancer, really that's part of the reason I'm here today. I'm a childhood cancer survivor. And this is how I've gotten into this. This is how I chose to become a nurse and a nurse practitioner and follow this path. It was because of my own experience, which I'm going to just talk to you briefly about today. Sometimes when I talk about it, I get super emotional. As you can see, I'm also very pregnant right now, which doesn't help with the emotional part. Last semester, I talked to it for the first time with my students and got really emotional. They didn't know I was pregnant at the time, and that has a little bit of a factor, but also it's interesting how all these years later, sometimes I'm super emotional about it when I talk about it. I don't actually even talk about it that much. Other times, it's like a lifetime ago. Like I don't even, like it's almost like I'm telling a story, that it's not even something that I really went through. So we'll see how it goes today. I'm not sure which one. But next year, 2018, is a really big year for me as far as milestones. I will be 40, and I will be a 25-year cancer survivor. And so basically, my story is that when I was 15 years old, I was a freshman in high school, I'd had a totally unremarkable childhood as far as illness, like totally fine, no problems at all, no surgeries, no broken bones, nothing. And when I was 15, I started developing this pain in my leg. And I would describe it as, I always described it as a pain in the groin area, right where your leg attaches to your body on the inside. And I would have this pain pretty regularly. Sometimes it was pretty intense. Other times it wasn't too bad. I was playing sports at the time. If I really got into the game, I could totally forget about it. But it just progressively got worse and worse. Other things that I noticed at the time as far as symptoms were so tired all the time. But I was a kid, and so I could easily justify it with that I was, as a freshman, so I was going to a new school. It was further away, so I had to get up earlier in the morning. I was playing sports, and when in junior high, we only played 3 days a week. And then in high school, I started playing every day. The sports seasons ran into each other. There's no break in between in high school. So just tired from that, right? Makes sense. Another symptom that I had that I don't even know that I honestly told anyone, but when I was sitting in class, sometimes I would just be sitting there and I would get this pain that would start. It was a shocking, like if you've ever had nerve pain, then you know what I'm talking about. Like it was this pain where all of a sudden it would just shoot from either my pelvis or my lower abdomen, up my abdomen, and it was that shocking pain that makes you just stop in your tracks in what you're doing. But it only lasts like a second or two, and then it's gone, and I kind of like forgot about it, kind of thing. As a kid, a lot of times you just don't care or tell or notice that much. So I never really thought anything of it at all. So I eventually, January of my freshman year, I complained about it enough that my parents took me to the pediatrician, and she felt the area, talked to us about it, felt like it was probably just a pulled muscle, which seemed to make sense. I started playing softball, and I was so tired all the time that my parents talked me into quitting. So just take a season off, let this rest and heal, this pulled muscle rest and heal, and you can start playing again in the summer. So I did. And then I started playing softball in the summer, and I remember specifically one event where I was out in center field, and I said, in my head, I was like, oh, please don't hit the ball with me, please don't hit the ball with me, like I can't move. And so the inning ended. My coach had to carry me off the field. It hurt so bad I couldn't even walk. Put me in the car. My parents took me back to the pediatrician the next day, who felt a lump at this point. It had been 6 months since I saw her last. This was in June, after my freshman year. And so she felt a lump at this point. So she ended up sending me to ortho, who did an MRI and found a big mass, who sent me to ortho in Chicago. I was from Northern Illinois. Sent me to ortho in Chicago because they knew it was something they couldn't handle in our smaller town. So I went to ortho in Chicago and was introduced to an oncologist at that time, a pediatric oncologist. At that time, they wanted to do a biopsy, and they said that it was probably one of three things: a benign tumor, a Hodgkin's lymphoma, or what I ended up having, which is a malignant fibrous histiocytoma, which is a soft tissue tumor. So I remember thinking at the time, like, oh my God, how can cancer, they were hoping it was Hodgkin's. Hodgkin's disease is the easiest thing of those things to cure. And I remember thinking, oh my gosh, I can't believe, like I was fine, and then all of a sudden, I can't believe that my best hope is cancer. So I had the biopsy, ends up being what they hoped it wouldn't be, malignant fibrous histiocytoma. And I opted to start chemotherapy right away, which is actually a bad decision because I was so sick from the anesthesia that my first chemotherapy really went terribly. I was so ill. I was so ill that when I went home, I didn't eat for 8 days. I lost 20 pounds in those 8 days. And actually, my parents have a picture of me eating for the first time after 8 days. I have some pictures of them and pass around. So there's a couple things now being a nurse that I think should have been done differently at that particular time. We were very new to the process, And really, I shouldn't have been that sick. As far as like, my parents should have called, and I should have gone in. There's lots of things you can do to help that type of nausea. I could have, done some IV antiemetics, fluids would have helped tremendously, those types of things. But we didn't know, and we didn't call, and that was one thing that really helped me as a nurse. These kind of experiences, to make sure to reinforce to people, like, call us when you need something, like, call us if things are bad, call us. But anyway, we didn't do that at the time, and I obviously lived to tell about it. But so I had started chemotherapy. The tumor itself was so big that they said it was the size of a Chicago softball, which is about 14 inches in diameter. And it was just growing and pushing everything out of the way. So when they did the biopsy, I asked the orthopedic surgeon, like, why didn't you just take it out while you were in there? And he said that, first of all, it's hard to remove. He said he's like, when you got through the outer layer of it, it was actually the consistency of toothpaste, is what this tumor was like. And he said to remove it, I would have had to take your whole left leg, half of your hip, your uterus, bladder, maybe a couple other things, because that's how you do a cancer surgery. You take everything that it's touching. And I said, well, thank you for not doing that. And anyway, so the idea then is to do chemotherapy, try to shrink the tumor as much as possible, so you can do more manageable surgery. Because with this type of tumor, you always take out home base, they called it, where it started. You always take that out. It turns out where mine started was the ischium and pubis bones. So, the bones that you sit on, they ended up, it was in one of those two bones. They said that it's hard to say with such a huge tumor whether it attacked the bone or came out of the bone, but it definitely involved the bone. So they considered that home base. So it was really not a good prognosis. My doctor at the time told us, he didn't want to give us numbers. He said that, he's like, the numbers don't matter. He said, it's 0% or 100% for you. He's like, it doesn't matter what happens to other people. Like, that's what it is for you, 100 or 0. So they said that although a lot they'd be able to tell a lot with how it went, how the chemotherapy went. And it would either really work well, or it wouldn't, and this tumor is very fast growing, it would take over quickly. So I ended up being lucky enough that the chemotherapy worked great. The tumor went, after my first round of chemotherapy, they imaged it again to see and it had gone from 14 inches to 2 inches. And then after a couple more rounds, it went from 2 inches to not being able to be detected on scan at all anymore. So when they went in to do the surgery, my doctor actually said it was amazing that typically when tumor retracts, it leaves scar tissue, but mine left nothing behind. Like, it didn't look like it had never even been there. But when they did look at it with the microscope, those bones that they took out did still have cancer in them. So it was, ideal to take out home base, like they said. I ended up continuing chemotherapy because they said it was kind of like an insurance policy. Like, they took out everything they can see, but you can't, these cells are so small you can't see them on imaging until they're pretty big, until there's a lot of them making a tumor. So it was like my insurance policy after the fact to keep doing the chemotherapy. So I finished the chemotherapy. I missed my entire sophomore year of high school. I finished the chemotherapy, and then in July of the following year, right before my junior year, I went in for so you do imaging right at the end as your baseline, and then you come back at 3 months and redo all the imaging, and you do that for a year, at least a year, usually 2. And at 3 months, the tumor was actually back, the size of a golf ball. So I had to start again. This time, though, the chemotherapy wasn't working as well. It was still working, but not as well. So they decided to go ahead and take the tumor out and do radiation at that time. So we went ahead and did radiation, and it was radiation. I don't know if very many of you are familiar, but basically what you do is you go in, they do all kinds of imaging to line it up just perfectly, and then they do little tattoos on your leg, just little spots of the ink to so that they can line you up the same every time, or obviously with my leg, other people depending on where their radiation is. And then they ended up, and then you go in it takes like 5 minutes once they get you in there, every day. Mine was 5 days a week for 5 weeks. And they did really, and they told us up front, they recommended the highest dosage possible for this particular tumor. And they knew there would be late effects of that, but the way it was described to me after was, they said, but we couldn't care. Like at that time, it was more about your life than how things would be eventually. So, so I did the radiation, did more chemotherapy. I went back to school as a second semester junior, back to high school as a second semester junior, and the radiation seemed to take care of it as far as the cancer coming back. But when we talk about these late effects of childhood cancer, my effects have been lymphedema. So my legs started swelling a bit when I was a senior in college. It took years. The radiation changes happen over years and years. So as a senior in college, I noticed that my left leg was starting to look a little bit bigger than the other. And over time, it's really just gotten worse. And then it's taken a long time, but I figured out mostly how to control it pretty well. A lot of people don't know much about lymphedema. Most doctors know very little about lymphedema. So it's been a struggle. But that's actually why I couldn't come on Friday, is because when you have lymphedema, you're at higher risk for infection. And that makes sense because, if you think about a leg that has some extra fluid in it that can't get out, right? So if any sort of bacteria gets in there, it just sits, right? And someone else who doesn't have lymphedema, the fluid keeps moving, so any of that bacteria keeps moving through the body. So it just ends up sitting there for a bit, which gives the bacteria time to replicate. And so before you know it, all of a sudden on Thursday, I had this terrible pain in my pelvis that I knew was a cellulitis because I've had them in the past, and it's a specific pain. And so my leg was all red, it looked like a sunburn, had a terrible fever, can hardly walk on it. This usually goes on about 2 to 3 days. The first few times it happened, I had to be hospitalized because I didn't know what was happening, and it had gotten so bad by the time I got antibiotics that I had to be hospitalized over it probably about 3 times. I've probably had cellulitis, I don't know, more than 10 times so far in these however many years. But you just don't know when it's going to come on. And unfortunately, it came on this weekend, so that's why I had to miss on Friday. And then others are secondary cancers, which I actually just had a secondary cancer in 2015. I noticed a bump behind my ear, my left ear. And so I finally showed it to my dermatologist, who sent me the ENT, and it ended up being I think what it was called, a mucoepidermoid carcinoma, which are super rare, definitely super rare in someone under the age of 40. And so I had that removed, and luckily, because I noticed it before it became a problem, before it had moved at all, they just monitor it. And that's all I had to do with that. And my doctor at the time said, it's hard to know what caused it. Is it that I've had so many, so as part of your follow-up, you have CTs of your chest because cancer most likely is going to go to your lungs next when it spreads. So I've had so many CT scans over the years, is that what caused this tumor in the ear? Like, you never know. Or is it just that I have a problem with cancer as far as my body recognizing and fighting it? So these are the things that I think with a childhood cancer or any cancer, I always think of it as a chronic disease because it really is never really over, unfortunately. Some of them get away. Some people, a lot of times your leukemias definitely have long-term side effects too, potentially. But a lot of times with leukemia, you don't lose any body parts over it. So a lot of times I think they end up faring a little bit better, depending on their situation. Because of how much I loved my nurses and my nurse practitioner, although I really loved my doctor too, is why I went into what I did. Because otherwise it sounds pretty terrible, doesn't it? Like, working with kids with cancer, like, doesn't that sound like the saddest job in the whole world? I didn't know how people got into it otherwise, but I have loved it for lots of years now. I worked in Chicago at the biggest children's hospital on their HEMONC stem cell transplant floor for about 7 years. I went to grad school while I was working, and decided to be a nurse practitioner, went to grad school in Chicago while I did that, and then ended up doing a fellowship at St. Jude in Children's Research Hospital in Memphis, Tennessee. They offer one fellowship per year, and I did that back in 2005. And then ended up working as a nurse practitioner there for about 7 years before I got married, had a baby, and ended up moving away. But one thing I wanted to mention is that your particular stage, this being a second semester junior, it's so exciting for you. I don't know if you're excited or if you're a little like, because it's almost done. But I've loved being a nurse, and I hope that you will too. But it's a matter of finding something that you really like. And it may not be your first job. You may have to jump around a little to find out exactly what that is. But I would advise that you pick a good one. Pick your first job would be a really good one. Like, you are not going to leave you're not going to leave school being a good nurse. Your first job will make you a good nurse. And so you want to pick wisely as far as, like, you really need to pick something that is really challenging to you, something that you really think you're going to like, and something that keeps you on your feet and moving. There are some nursing jobs that you can really, like, sit around a lot more than you should as a new grad. Given the opportunity, you will learn a million more things in your first job than you did in school. So pick a good one. I feel like I picked a really great one, and I feel like, I mean, not to be like, but I'm a good nurse, and I am a good nurse because of my first job. It was one of those, like, you ran from room to room. You were so busy all the time. There was so much going on. There were sick patients. Some days you just didn't eat. You just didn't. There just wasn't time. I had such good colleagues, learned so much from them. Everyone was so good about helping each other out. Like, that's the kind of job that will really help you. And that's what I would recommend, especially for a first job. But moving on, so we don't run out of time, I will pass around a couple pictures. These are just some pictures of me bald, essentially. One is with Jim Harbaugh. He was the quarterback in Chicago when I was ill. He was really, really great about visiting and cancer charities. Really great man, actually. And then one is we did a Make-A-Wish trip, which I'm going to talk a little bit about Make-A-Wish later, to Hawaii. That was my wish, was to go to Hawaii. And so there's a picture of me and my siblings with leis on. My parents threw a surprise 16th birthday party for me. And you can see me with the cake and my hat. One thing that you should know about losing your hair is that it is freezing, more so than even, like, it doesn't, it's better. You usually like your hair showing, but it's so cold without it. That I used to wear some sort of bandana underneath a hat in the winter because you didn't even realize what your hair does for you in these winter months. And then the last one is when my hair started coming back. I was asked to be in a wedding with this very ugly green dress. But, and so my hair was about this long. And so there's a lot of stages to go through before it grows back. Any questions? One thing I think, too, about working with kids with cancer is that one question that people often have is, how it's supposed to be so sad, right? And the truth is, it is, a lot of times. There are some very sad things. And I have definitely cried lots of tears over lots of patients. But the truth is that for me, I think what got me through these kind of things is that, I didn't necessarily, a lot of them do really well, really, really well, and that's so nice to see. But the ones who didn't, in my head I didn't differentiate really where they went. Like, they weren't my children. So I wasn't used to seeing them every single day, like you would your own kids. And so whether they died or whether they got well and went away, either way they went away, right? So I didn't really spend a lot of time thinking about, where they were, essentially. I think that as a nurse, I chose to be a nurse over a physician because I didn't want my job to be, I feel like a physician's job is a little bit more behind the scenes, diagnosing, looking for cures, doing research, and what I really wanted to do, I didn't feel like that was my role. What I really wanted to do was I wanted to help them through the best they could. They're in a bad situation, and I just wanted to help get them through as easily as possible, and that's why I chose to be a nurse. But getting back to the lecture, your book talks about cardinal symptoms of cancer in children. I've never really heard it called cardinal symptoms before, but these are symptoms of childhood cancer. I'm not going to read them to you, but I did want to comment on a couple of them. And what I want to comment on is, if you look at them, like, these are normal things, right? Sometimes it's not totally unusual to have a kid get hurt and have them swell a little bit, have a little mass that you think is probably like, hematoma or some sort of bruising or, something else. You definitely don't jump to cancer as your first thought as a pediatrician or as a parent or anyone. So all of these things, happen. If you see toddler boys, like my own toddler boy, you look at his shins and you think, oh wow, like, should he be checked out? These look bad. But you know what? It's because he is a rough kid, and he's always getting hurt. But the ones I really wanted to comment on were the unusual mass or swelling. So often these end up being silent. A lot of times they're in the abdomen or somewhere where they have room to grow, and so they don't necessarily present themselves right away. So it can be a while, and then parents can be so upset with the doctor for not finding it sooner, with themselves for not noticing, because hindsight's 20/20. So it's easy to say after you get your cancer diagnosis, oh, I did notice that, or oh, I just didn't think anything of it, and I should have, kind of thing. So there's a lot of times there's a lot of guilt. And I've also found, being a nurse, moms, dads maybe too. Dads often aren't as vocal as mothers about things. Mothers often try to find a way to blame themselves. My own mother, with my cancer, she forced me, I did not want to go on a ski trip. She forced me to go to ski trip in Wisconsin. I had never skied before. It was terrible conditions as far as, like, it was so icy, and I fell probably a million times on my butt. And so my mom thought forever that she caused my cancer for for making me go on the ski trip. And she was sure that that was what caused it. And finally had to be set straight by the physician that really is not what caused it. Another mother once told me her son, her 14-month-old, was diagnosed with leukemia, and she was an older mom. She was 44 when she had him, and she said, "Did I do this to him because I was such an old mother?" And the doctor right away jumped in and said, "No, you did not do this to him. Like, this just happens. Moms often find a way." So that is one thing as a nurse to consider, if something like that comes out, to really identify it and set them straight so that they don't have to feel this kind of guilt. Like, whatever the mother did, they did not cause the cancer. Other things I wanted to mention were the headaches. Frequent headaches, often with vomiting. And it's often with morning vomiting. And this is typically a brain tumor. And so when someone complains of headache, there's lots of reasons to have headaches. In kids, or actually really in anyone, you start to worry about headaches when it's in the same place every single time. That's a big thing, when it's in the same place. And then the morning vomiting, because they've been laying down. So if there's an increase in intracranial pressure when they get up, then it causes them to vomit. And then excessive rapid weight loss, I also wanted to bring up. In kids, this is a little bit harder because they don't have as much weight as an adult, right? So I feel like if you hear this a lot in adults that, people diagnosed with cancer, they've lost a ton of weight without trying. That is a huge red flag. If you, as an adult or as a child, when you're losing weight without trying at all, and it's a lot of weight, you need to be thinking about cancer, unfortunately. That's a big, big red flag. So in diagnosis, basically what's going to happen when you suspect a child has cancer, you send them to someone who deals with that, right? And what they do is they do a complete history, they do a review of systems, and then they do a very thorough exam of everything. And when I'm talking about complete histories, I used to ask parents of 18-year-olds, was this child delivered via C-section or via vaginal birth? What was their birth weight? Did they have any problems? And the parents are kind of trying to remember. This kid's 18, But we were part of a research hospital, and we wanted to know everything. We wanted to try to figure out the connection of all these things. It's a very thorough history, very thorough physical exam. They're having pain here, you still examine every single thing. Then you do lots of lab tests. You do your complete blood counts, your chemistries. Certain tumors that you're suspecting have different markers, so you would potentially draw blood for those. And then they may or may not get a lumbar puncture, which is a spinal tap, depending on what kind of disease is suspected and what's needed for the workup. And then imaging studies, you do a biopsy of the bone marrow or of the tumor itself. Bone marrow would be something for leukemia. You definitely have to do, you can't just, there's not a tumor to biopsy. Leukemia is a cancer of the bone marrow. You get your sample of the bone marrow that way, through the bone marrow. Or if you have a solid tumor, you do the biopsy that way by taking a piece of that tumor and looking under the microscope. So lumbar puncture, I don't know if any of you have actually seen one or had one done, but basically you can do it anywhere in the L spine, usually between L3 and L4. Stick a needle in and pull, and the fluid actually drips off. And you collect it in a tube. It's a very sterile procedure, obviously, because we don't want to give them meningitis by exposing their CNS to any sort of bacteria. And this is something that's done by either a nurse practitioner or the physician. The bone marrow aspirate and biopsy is basically the biopsy of the bone marrow. And the way you do it is you sedate them. You take a big needle and you put your fingers around the iliac crest in the back, In older kids, you can do the front, but there's more risk in the front because there's more vessels to hit. So typically it's done in the back and the posterior iliac crest. Put a big needle in, you turn it. It seems really like you use quite a bit of force. It's really something that parents leave the room for. Are always asked to leave the room for. Basically, you end up sucking out some of the marrow with a syringe. This is the part supposedly that really hurts. I haven't had it done myself, so I don't know, but that's the part that really hurts, I guess. Then you end up doing using a second needle, and you really, it's almost like a screwdriver, screwing it in. You pull out the piece that, with the actual sharp point at the end, you pull out that piece, and it leaves the outside of the needle. You put a different piece in to cut it, and then when you pull it out, you have a sample size that looks like a pencil lead, essentially, is what it looks like. And that's how you do the biopsy and aspiration. Staging is something that's very important. I would star this. Staging represents the extent of the disease at the time of diagnosis. So it's important for two reasons. You want to determine the treatment plan by the type and the extent of the disease. And it also gives a prognosis for an individual patient. Some people will say, you know, like, oh, I was a stage 4, but now I'm a stage 1. Like, basically, all the treatment is based off of what it was at the beginning. It doesn't really matter how it progresses. Like, everything is based off of the beginning, how it presents. So your modes of surgery, our modes of therapy, our surgery, chemotherapy, and radiation are some of the big ones that I'm sure you've all heard of. So surgery, you either remove the tumor, or you can also debulk a solid tumor. And what debulking means is sometimes when you just cannot take that tumor out for various reasons, you can take part of it out to relieve symptoms, to relieve pressure on vessels, to relieve pain. And all of surgery always is also you need to determine whether it's curative or palliative is the intent. So you do things differently if it's curative versus if you're just trying to make the symptoms better. With chemotherapy, all the patients are put on some sort of a protocol based on best practice, based on what we know to be the best thing for this tumor at this time. And they give different combinations of the drugs to kill the cancer cells in all different stages of the cell cycle. So that's why you get different drugs, because it works on different stages of the cell cycle to try to kill them, because they're all changing at different times. And then one thing I want to say about chemotherapy is, does anyone know why it makes your hair fall out? We all know that it does, right? Does anyone know why it does that? I'm sorry? Yeah, so basically, chemotherapy does not differentiate between good and bad cells. It doesn't know cancer cells. It doesn't just pick out the cancer cells and try to kill them. What it does is it goes after your fast-growing cells. Cancer cells are fast-growing hair cells, your bone marrow elements, so that's why your counts, you have problems with your white count and your blood counts. The epithelial cells of the GI tract, so a lot of mouth sores and things like that, because those are rapidly changing, and so the chemotherapy attacks those things in addition to. And then things like the handling of the drugs is done in a very special way. You know, this is poison. We're essentially putting poison in people. And the last thing you want to do is expose people who don't need it, right? Or expose them more than they need to be exposed. So basically, as a nurse, you wear, when I was young, when it was first started, we wore double gloves. That's what we did. But now they have special chemotherapy gloves. You wear a gown, you wear, they make you wear goggles, all kinds of things, a mask with a shield, to prevent from you being exposed. Everything is done under a hood in the pharmacy. It used to be, when some of my older colleagues did it, they used to mix their own chemotherapy back in the day with nurses. But they don't do that anymore. And then the side effects, actually, we'll get into later, but they're the ones that you know of, like hair, blood counts, nausea, those types of things. And then there's always a risk of anaphylaxis, some drugs more so than others, so there are definitely protocols in place on how to give some of these drugs and what to do if you would have an anaphylactic reaction, if the patient would have an anaphylactic reaction. And then also risk of extravasation with vesicant drugs. So some of your drugs will need to be given through central lines because you give it through a vein and it gets out of the vein for some reason and it will burn all the tissue around it. It has to be in the vein. And that's what we call extravasation. So radiation. Same with radiation, it can be curative or palliative, just to relieve symptoms. And the side effects depend on your area that's irradiated. So your GI system, for instance, you can have diarrhea, sores, blood, nausea and vomiting. Things like your skin, you have burning to the skin, it looks like a sunburn, sores, and potentially skin cancers later on. And then in your hair, you have, or in your head, if the radiation will make the hair not grow back to the area that you're doing, the area that you're doing the radiation to on your head. It also affects the non-cancer areas of the brain, unfortunately, which can cause long-term problems. Nausea and vomiting, sores in your mouth, decreased saliva production, difficulty eating, depending on where in your head the radiation's happening. And then long-term effects depend on your site. So with GI, you can have chronic diarrhea, you can have adhesions. Skin, you can have skin cancers later on. Head, potentially things like memory, it can affect your overall intelligence. You know, these kids, that's part of the problem of irradiating a brain that's still growing, right? Is that they haven't reached their full potential. And so a lot of times that can affect their overall intelligence to do radiation when they're young. And then just there are lots of side effects of the brain. It totally depends on which part of the brain is being treated. Another thing is stem cell transplant, and I think stem cell transplant is super interesting myself. I'm not going to read all this to you. I also don't think it would be important necessarily for a test, but one thing that I really want to point out of this is that it's very non-dramatic. It is one of those things that you give chemotherapy, you want to kill all of their bone marrow. When it's what you want to do with a leukemia. And then your solid tumors, you want to give such high doses that it actually kills off the bone marrow. So you have to give them cells back. But it is one of those things, you give them chemotherapy for a few days, and then the stem cells are given by IV infusion. Things are very dramatic on TV. It's probably a little bit more dramatic with a solid organ transplant, but that's all it is. You give an infusion. The issue is that time that they have no counts when it's trying to build back, and so you need to keep them well. They need to be in a certain isolation rooms in the hospital, and for those 10 days, especially, it's worrisome. A lot of things can go badly. So the use of central lines are really important in cancer therapy. The nursing staff and parents really need to be trained well. And I was wondering, if you look at this, do you see, does anything look scary about this to you? About central lines? It goes, yes, exactly. It goes directly to your heart. See how it goes right in here and it dumps into your heart. So whatever you put in that line, it's going straight to the heart. So you need to be really careful as a nurse and really take that seriously as far as like, doing what you're supposed to, having clean hands or gloves. In addition to that, using sterile technique to change dressings, using alcohol swabs every time, those types of things, because you're going to dump whatever it is into their heart. The complications of these lines are infection. Sometimes they clot off. You have to be careful in kids how much heparin you use. And in this particular, and these lines, you're supposed to use heparin at the end each time. You can have lots of skin irritation from the Tegaderm or other adhesives. They get pulled, they break, as you can imagine. Keeping these lines in small kids, like, what's this? You have to be very careful with them. But they're really, really great to use. You draw blood from them. You give IV meds and fluids. It's very much more durable than an IV. Same thing. A venous port is the same idea. It's also called a portacath. These are actually implanted under the skin, so you put a needle in them every time. The advantage of that is that there's no care at home. Families don't have to take care of it at home because you put a stronger heparin in it and then you just reaccess it every time they come in the hospital. So that's one big advantage of the venous port, where the other hangs out all the time and the parents have to learn how to take care of it at home. So the emotional aspects are basically, it's a super difficult diagnosis to deal with. Cancer is just often associated with death, and it's really, really hard on the family. It's a new lifestyle. It's completely overwhelming. Like life is kind of halted for this in many ways. The treatment's intense and it's often very unpleasant. There's a lot of denial in families at the beginning. Not everyone, but it's just a coping mechanism to get through something really difficult. Fear, anger, guilt. We talked about this a little bit before when a diagnosis is initially made or delayed, missed initially or delayed. And what they really need from a nurse is just tons of support. They need the information repeated to them over again, over and over. And you'll feel like you talked to them about this before, and you probably did, and you just need to keep doing it until they get it. Because, when you're so overwhelmed with grief over this happening to your child, it's really hard to just jump in and learn everything right away. And sometimes written explanations really help too, because they can take it with them and review it later. Other things are to know your resources as a nurse. Families should be exposed to things like support groups. They don't have to do it, but they should know that it's available. The Make-A-Wish Foundation is really great for anyone with a childhood illness, anyone who's 18 or younger with a life-threatening illness. A lot of times people get scared of it when people come in to talk about it, because they're like, oh no, we're going to make it. It's not for kids who are dying. It's for kids who have a life-threatening illness. Support for siblings. You always have to remember the siblings. They have a really hard time. And a lot of times parents try to protect them and not tell them a lot. But, kids know. They hear things. And if they don't, a lot of times they make things up in their head. And so they really need to be part of everything that's going on. Ronald McDonald House is somewhere as a good charity for someone to stay when they're staying away from home at the hospital setting. Child Life is really good about, if you're not familiar with Child Life, really good about talking to the kids at their developmental level. That's their expertise, is kids in their development. So if I talk to the family about getting a port, Child Life usually will come in and they will bring a doll that has a port, show them how to handle it, and really make it so the child understands in their own terms. And then psychology should always be following. Lots of times the family needs it too. That's a little bit harder as far as resources, but psychology usually follows all these kids. One picture, this is a patient of mine that I've gotten permission to use the picture. I thought it's so cute. Her and American Girl doll. These dolls, they're now available that you can buy them for a child with cancer, and they will come bald. And then when the child's hair comes back, you can send it back to the company and they will put hair on it, which I thought was just super sweet when I learned about it. Managing the side effects of treatment. So basically, with low blood counts, what you do is you give them a drug called filgrastim, and that helps boost the immune system, helps boost the white count, and makes it come back faster than it would otherwise. And then you give blood and platelet transfusions to support them through therapy as they need them. Infection, you use neutropenic precautions. Neutropenic precautions, basically, one thing I want to point out is the biggest thing with neutropenic precautions is good hand washing, just like any other illness, right? But basically, you also, when you know their counts are low, they wear masks, they stay out of crowds. You definitely don't go to the movie theater. My doctor told me don't go to church. People go to church sick. Do not go to church when your counts are low, is what my doctor told me. So you stay away from, like they can sometimes go to some events, depending on how well they're doing, if they're outdoors. But if their counts are really, really super low, those couple days, you keep them kind of home and away from ill people. Fever I've started because it's a big thing. Fever in kids with cancer is your only indication that something is really going on. Typically, say you cut your finger and you know how it will turn red, and then sometimes you get pus, and this is all your reaction from your white cells, right? Well, you don't have white cells, very many of them at all, when you're neutropenic, when your counts are really low. So basically, you don't have any of those warnings. All you have is fever. So I would tell parents, if a child has a fever, and you discover this at 2 in the morning, you bring them to the hospital at 2 in the morning. You don't wait till the morning, because sometimes the morning is too late. Like if you have a big bacteria going and they have no way to fight it, no fighting power of their own, then it can be too late. Like things happen quickly. So you bring them in the minute you find out. And then you start antibiotics within 30 minutes of them arriving, because it's really one of the most dangerous parts. You're more likely to have, kids are really more likely to die from some sort of infection than they are from their cancer during therapy. The nausea and vomiting, one big thing is to always give antiemetics prior to chemo or radiation. It is always, 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 always easier to prevent nausea than to take it away once it comes. So always, even if they do really well, you still give them something like Zofran or whatever prior to their chemotherapy or prior to their radiation. And altered nutrition, appetite stimulants, tube feedings, TPN when they just won't eat. And then they also will have problems with mouth sores, and there's really just nothing you can do to prevent them. What you need to do is you keep the mouth really clean, and then you do some sort of pain control if needed. But that's all you can really do for the mouth sores. One slide I added yesterday. And then we'll have to stop here because the time is up. I guess I'll have to integrity the rest. Right? Till 10? Oh, good. I was looking at that 10:30 clock, and for some reason I was thinking it was 10:30. Oh, good. Okay. No, perfect. No, I have the right time on my watch, but no, I'm good. I'm good. Thanks. So I thought I was finishing, and I was trying to finish up in the last 2 minutes. Okay. So a teenager with Hodgkin's disease experiences severe nausea and vomiting when receiving chemo for the first time. What's the most appropriate nursing action to prevent or minimize those reactions with subsequent treatments? you want to give the antiemetic before chemotherapy begins. So let's talk about the other ones just briefly. So administer chemotherapy between meals. I don't think it will really do anything between meals, whether you're giving it during, while they're eating or not. Like, what they really need is they need an antiemetic. So Zofran and ondansetron works really, really well. It was developed to, the reason why it works so well is it was developed to work with medication-induced nausea. And so it really just works great for chemotherapy. That was always our first line. And then we added other things as needed. I always told families they needed to have it before, then give it every 8 hours for a couple days after. Then after that, to give it as needed. But for the same reason, like you say they're doing really well, you take it away, like they get sick and it's really hard to get rid of it. So just keep it going. Have them bring in favorite foods for snacks. This is not a good idea because a lot of times they end up with some sort of aversion to their favorite things. I had this thing when I was 16 they used to have like a strawberry kiwi Snapple was my favorite thing, my favorite drink. And so one of my cousins brought it to me at the hospital, and I drank it, and then when I vomited, it came up like an acid, and to this day, have never had it again. Actually in college, I was learning about aversions in one of my psychology classes, so I went and bought one after class because that was not going to happen to me. I'm not going to let these mental things take over, and I ended up trying it. It was terrible. Just never liked it again. So a lot of times you don't want to give them their favorite foods because when it comes up again, they may not like it ever again. So save that for times that they're feeling well. Keep the child NPO until the nausea and vomiting subside. They will probably keep themselves NPO, right, when they're sick like that. And then wait and administer chemotherapy while they're sleeping. They will wake up sick. Like, you just need to give them the antiemetics that they need, basically. Nursing considerations in cancer therapy is that nurses need to be chemo-certified. When I was a floor nurse, we took lots of different classes and had to take tests to be certified because, these drugs have to be given a certain way. And there's lots of different things about each one that the people need to know about. So really, the places I worked at, you for sure had to be certified. I don't know how it works in smaller towns or with adults, but really nurses need to know what they're doing. So nurses will administer the chemotherapy, they administer the antiemetics, they administer pain meds, they help manage side effects. They're the ones who are there all the time. So you're the one who's in a really good position to really make this go well or not for the family and for the patient. We don't do any rectal temps. So rectal temps is your most accurate way in kids to take a temperature. But we don't do that in oncology because that area, the anal area, is the rectal area is very vascular. So you really just don't want to poke around down there. You don't want to cause bleeding, and you don't want to cause any sort of infection. It's also, a dirty area, so you don't want to cause infection in these kind of patients. We do no ibuprofen. And why would ibuprofen be bad in a cancer patient? I'm sorry, I can't. Say it again. I just can't hear you. So Tylenol affects the liver more so than ibuprofen. The issue with ibuprofen is it's a platelet inhibitor. So basically, you don't want to give it to people who already have low platelets to make the platelets that they have not work, right? So it can cause bleeding, and we just do not give any sort of ibuprofen, any sort of aspirin you don't give to kids anyway for different reasons. But they can have Tylenol, but Tylenol also needs to be very supervised because Tylenol masks fever, right? And we need to know if these kids have a fever. So it's usually just given in the hospital setting when we already know that the patient has fever. And because Tylenol really is just for comfort for the fever itself, because fever makes you feel pretty terrible. And then the nursing responsibilities also are tons of teaching. You teach about the disease, you teach about chemo, you teach about the central line, about mouth care, about blood counts, and you teach them again and again and again and again until they get it. And you'll be surprised how quickly parents really become an expert at this. They don't think they will, but they do, and it's really remarkable. And then just to support the parents and the children, remember that they're constantly living with fear. They have altered family processes. You know, they have a sick kid. They're trying to maintain their life at home. Like, someone needs to work. Someone needs to have insurance. The other kids need to go to school. Like, this child with cancer still needs to be educated. Like, there's lots of things. It's really difficult. And they just need support through that. And then also anticipatory grieving. A lot of times if it's not going well, whether or not the parents are actually told, and they usually are told, they know. The child knows, everyone knows. And a lot of times there's a lot of grief knowing what's to come. Health promotion. So mouth care. We do mouth washes multiple times a day while neutropenic. We do PCP pneumonia prevention. So PCP pneumonia is a certain kind of pneumonia that is more prevalent in people with low counts, your HIV patients, your kids with cancer, or people with cancer. So basically, it's really hard to get rid of. They get super sick. ICU usually die from this. And so basically, prevention again. You give them Septra twice a day, 3 days, every single week throughout their entire therapy to prevent it from happening. And then immunizations. These kids cannot have immunizations while they're on therapy. And the reason why is because they don't have a good enough immune system to build a response to make the immunizations work. So this is why I'm a huge proponent of immunizations. And this is one of the reasons why. Like, everyone needs to be immunized to protect these people. Like, you protect the people with cancer, you protect your older people, you protect your babies. And these people can't do it themselves, so the rest of us need to protect them with immunizations. Once they're done with therapy, you catch them up in their immunizations. So wherever they were, you restart their immunizations. And then after a transplant, though, it wipes out their entire immune system, so you need to start over completely from the beginning with immunizations. And with the nursing stuff, you also need to think about things like school. They need to be reintegrated as soon as possible. They need to be tutored until they're able to return to school. And then also illness exposure is something to consider before returning to school, because they need to have some decent counts before they go back, or they're just going to start getting sick. Because, as you know, everyone at school is sick all the time. And then we start screening for long-term effects from this very toxic therapy. They, a lot of times, have delayed growth. This didn't happen to me. I was already this size when I was 15. But some of the younger kids, have a lot of growing to do. And a lot of times chemotherapy will stunt their growth. Secondary malignancies, something to always be on the lookout for. Because, these therapies actually can cause cancer. But it's the best we have at this point in time. There can be disturbances really in any body system from these drugs. They need regular follow-up. Fertility is an issue for lots of people post chemotherapy. So one of the big things now, like we did sperm banking. We offered sperm banking to kids who were typically 10 and older when I was working still. Now they've come up with somewhat better options for women too, just to save eggs and stuff. That was really very difficult. It's a difficult thing to do. You want to get their therapy started. It's also much harder to harvest eggs than it is to, get sperm in a cup. So anyway, so they're really working with that so that there's more fertility options for people who have. I was very fortunate in that I didn't have those, as you can see. I didn't actually have any of those problems, but a lot of people do. And then genetic counseling. Some of these cancers are familial, and some families carry certain genes that predispose them to cancer, and it's something to think about for these families. We had one family in particular at St. Jude, I'll never forget them. This boy had a Wilms tumor when he was 7, lived from that, had an osteosarcoma when he was 12, lived from that, and died of leukemia when he was 19. His mom died of breast cancer. Like, they have what's called P53, which is definitely beyond the scope of this class, but and it goes right through their family. So there are things like that for some unfortunate families, which is unfortunate for some families. And then family education. The child and the family really, they just need help coping with this serious illness and their constant fear that their child will not be cured. And then, like I've said over and over, information, education need to be reinforced. And I've mentioned this too. They really quickly become experts in their child's care. Any questions on any of the general cancer stuff? Okay. We go through the types of childhood cancers. And one of the ones I wanted to bring up is, first and foremost, is leukemia, because it's the most common. And leukemia is a cancer of the blood-forming tissues. It's a cancer of the bone marrow. The peak onset is definitely not something to memorize. I just really put it up here for reference. It's usually 3 to 5-year-olds who get this. And this is the patho of it. It's the unrestricted proliferation of immature white cells. So basically, these white cells start growing out of control, and they do nothing. They don't work at all. Okay, so they are just taking up space, and all the space in the bone marrow. The bone marrow, primarily in children, the place that primarily makes the white, red cells and platelets is the long bones of the leg. So these kids end up having these white cells go crazy, which keeps the red cells and the platelets from forming. And then, so there's not enough of them. And then they also kind of get stuck in the bone, so then it causes pain. So those are some of the main symptoms. But basically also, these immature white cells are called blasts. And blasts are not normal in a blood count. When you do the blood count and look at the smear, you should not see any blasts. If you do, you should always just look for leukemia and do the workup for leukemia. So basically, we had a patient who was 14 months. He started walking at 9 months, and then at 14 months stopped walking. His parents didn't know what happened, why he stopped walking. And they took him to the doctor, thought maybe his leg got caught in the crib, didn't know, couldn't ask him. He's 14 months. So the doctor did a blood count, and his white count was actually normal. His hemoglobin was 8 when it should have been anywhere from 10 to 13 or so at that age. And his platelets were 75,000 when they should be anywhere from 175,000 to 150,000 to 450,000. And so the doctor actually prescribed iron, which was not the right thing to do. When you have 2 cell lines down like that, the platelets are down and the the red count, the hemoglobin is low, really there needs to be further investigation. There's something not right about that. So prescribing iron, iron deficiency anemia is common in children, but their platelets should be fine. So that was something that wasn't done quite correctly. So when he came, when she decided to send him, the doctor decided to send him to a hematologist. It was found these 2 cell lines were down, and these were actually very classic symptoms of leukemia. Legs hurt. So he did what a child does. It hurts to walk, so I'll stop walking. I'll just crawl. They don't complain. They don't whatever. They just adapt. So anyway, so that is some of the big red flags of leukemia in children. So these white cells, like I said, not normal, don't do anything. So these kids get really sick. They have frequent infections, they have fever, their lymph nodes become enlarged because these white cells get trapped in the lymph nodes. They have pain. They're pale, weak, have fatigue because of the red cells being down, loss of appetite, shortness of breath, easy bruising, difficulty bleeding stop, petechiae. Petechiae are the flat, pinpoint, non-blanching red spots that are due to bleeding underneath the skin, all because of their platelets being low. And then typically they have some sort of hepatosplenomegaly, so their liver and their spleen are big because those are both filtering organs, right? So a lot of white cells will get stuck in there, making it big. Sure.
So increasing white blood cells, is that like healthier?
No, they make it worse because they don't function correctly. So they don't fight infection at all. That's why they get sick. So ALL versus AML. ALL is much more common, thankfully, much easier to cure than AML. The reason why I put this picture on here is I just wanted to show you, remind you of how blood cells start out. And you can see the lymphoid system only involves this much, right? The T cells and the B cells. Whereas the AML, the myeloid system, all of this happens under the myeloid system. You see how that? So it makes it so much harder to cure. And their survival rate is only about 65%. And it depends on what type. There's 12 different subtypes. Definitely not something to get into today. But it's much harder to cure AML than ALL in children. So in the diagnosis and treatment, I mentioned no blast should be in peripheral blood. So if it is, you need to, you need to suspect leukemia and work them up for that. And diagnosis is made by the bone marrow aspirates and biopsy results that we talked about. It's a very complex disease classification system that we won't talk about today for sure. Their treatment, basically ALL treatment is 3 phases, AML treatment is 2. Also not something to memorize, but I just want you to let you know kind of how it goes. Therapy lasts for 3 years, 2.5 to 3 years. A little bit longer in boys because the leukemia cells kind of like to hide in the testicular area, which is obviously not an issue for girls. So the boys end up being on therapy a little bit longer for that reason. First, you go through induction. The point is to give them very intense chemotherapy to kill off these cells and to put them in remission as fast as possible. The faster they go into remission, the better it will go long-term likely. Then you give them more chemo in the consolidation phase to help get rid of any remaining cells that might be there that you can't see. And then maintenance therapy is actually very easy in comparison to the other phases. They do a push chemotherapy typically about once a week, and they take some oral things. And that's the longest part of the 2.5 to 3 years. In AML treatment, the treatment is much harder. The disease is much harder to cure. So they actually don't do the maintenance phase. They just do the consolidation phase once they go into remission. And then they will do a stem cell transplant depending on the subtype of ALL and depending on, or just subtype of the AML and how well they've been doing, how easy it was to go into remission. Your lymphomas are primarily just involved in lymph nodes. It's Hodgkin's disease. It's a very predictable disease, very easy to cure in comparison to a lot of the other diseases. It has a 95% cure rate. They usually involves the spleen, the liver, the bone marrow, the lungs, and the mediastinum. Non-Hodgkin's lymphoma is much more common in younger kids than teenagers, totally unpredictable, and 20% of them actually start outside the lymph nodes. Some of the signs and symptoms. Hodgkin's disease, these kids are notey, like they have visible lymph nodes. One of the doctors that I worked with had Hodgkin's disease, and she said, she actually had it when she was in medical school, and she said one of her patients, she just didn't feel well a lot. One of her patients actually pointed out to her and said, she said she was working in downtown Cleveland, she said, you better get those big knots in your neck looked at, is what she told her. And so she did. She went in and she had a lymphoma. She could see the knots. The patient could see the knots in her neck. The classic symptoms are fever, weight loss, and drenching night sweats. So it's not like I have too many covers on, I'm sweating in bed. It's I'm sweating, I have to put a new shirt on, I change my sheets kind of sweat. Like it's a sweat, like a drenching sweat. And they are treated with chemo, and then this tumor responds actually really well to radiation. Of the non-Hodgkin's, 60% of the lymphomas are non-Hodgkin's as opposed to Hodgkin's disease. And they have different symptoms, coughing, wheezing, all these things. They're treated with chemo, and radiation usually isn't used. It doesn't work as well in non-Hodgkin's as it does in Hodgkin's. And one thing I wanted to point out to you is that when you have supraclavicular lymph nodes, when you actually feel those in a patient, they are almost always cancer. Like they are not, it is not normal to be able to feel lymph nodes here, just as you move along in your practice. And here's just a picture kind of showing what lymphoma looks like. Another, the next biggest cause of cancer in children is your brain tumors. So these are solid tumors of the brain or the spinal column. They are classified by the type of tissue where they begin. So like an astrocytoma begins in the astrocytes, and that's how they get their names, their different names. They diagnosed by MRI findings and biopsy results. And your most common is what I talked about at the beginning, like the headaches and the morning vomiting. And then other signs and symptoms are based on the location of the tumor. And there's some that are listed in your book if you want to look at that. So in infants, sometimes it's hard to know what is going on as far as, they don't complain about headache. And then also, they don't have symptoms quite as soon because their bones haven't ossified yet. So as the tumor gets bigger, the head gets a little bit bigger too. So a lot of times these kids will present with bigger heads and finally start to have some sort of symptoms, but theirs often get a little bit bigger than before they're detected than an older child, because the older child, the brain, it can only expand so much there's not room in there for anything else really. So when you have a tumor, you start having all the pain and the pressure of something in there that shouldn't be, because the head doesn't expand anymore. So your treatment of tumors of the brain are surgery, chemotherapy, radiation. Surgery is difficult because, and sometimes they're unable to get to certain parts of the brain via surgery because it's too dangerous. But it can cause injury to really other important areas of the brain. And then radiation is a problem because it causes tissue necrosis, it causes some tissue death, causes scarring. They end up having behavioral or intellectual defects. There's a lot of endocrine things going on in the head, so those things are affected by radiation. And then they end up also potentially having secondary malignancies in the head. Protein beam radiation is actually what's preferred for brain tumors because it's a more focused beam of radiation and it doesn't end up affecting the other tissues as much. Because with standard typical radiation, when it comes in, it also needs an exit space. So it's not going to stop at the tumor, it's going to keep going, and it'll affect all those tissues that aren't necessarily involved. And then the blood-brain barrier is an issue because the chemotherapy has a harder time getting there because of the blood-brain barrier. And so what's typically done is an Ommaya reservoir is put in the top. It's kind of like a port in the head. It looks similar to that. And that's where you actually, then you put a needle and you deliver chemotherapy right into the CNS. And that's the way of delivering that. So I'm going to skip for a minute in case we run out of time. Past Wilms, and past neuroblastoma, to osteosarcoma. So osteosarcoma is the most common primary bone tumor in children. The peak age is your teenage years. It typically presents as pain, and they often have a palpable mass on an exam. So this is very similar to what I had. I didn't have an osteosarcoma, but it was treated the same way as an osteosarcoma. And some things I think are super interesting about it that I wanted to bring up are that, so it's likely due to high cell turnover during an adolescent growth spurt. And patients with osteosarcoma are typically a little bit taller than their like-aged peers. And that one thing that's also interesting about it is, so osteosarcoma in dogs are typically in your big breed of dogs, your St. Bernards, your Great Danes. It's reported at 185 times that of small dogs. So there really is some sort of connection with growth spurt and height. And it typically happens earlier. Another thing is it typically happens earlier in girls, the osteosarcoma, than in boys. And girls often, that also corresponds with their growth spurt and puberty in girls happening before boys. So it usually happens around the knee. It's the distal femur, or the proximal tibia. It's typically where these tumors are. Sometimes the next most common place is the proximal humerus. Metastasis to the lungs happens already 15 to 20% of the time by the time they're diagnosed. And if you have localized disease, your survival rate's much better than with metastasis. One thing with cancer therapy is that once it moves, it's really hard to get a hold of. If you can keep it in one spot, which is what was always happened for me, your prognosis is much better. So you treat it by how we talked about kind of with mine, like you biopsy it, you do surgery, and you give chemotherapy beforehand to shrink the tumor to make the surgery more manageable. And then you do chemotherapy to finish. So limb sparing versus amputation. I used to think that amputation was like the worst thing ever. And they talked about that for a long time with me, doing amputation. I've since come to realize from being a nurse that some of these prostheses are so good that if you can keep your knee, depending on where the tumor is, if you can keep your knee, the prostheses are so great that you probably would just really go with that. But a little bit higher is difficult because the prostheses aren't as good yet, at least. And I wanted to talk about for just a minute about the nursing considerations. So with amputation or any surgery involving loss of body parts, you really need to be supportive during the planning period. You need to answer your questions honestly always. one thing that I found is that if the parents are there and a child asks a question, it's probably better to let the parents take the lead. A lot of times they want to, talk about a religious aspect of it, or it's just better to let them handle it. But if everyone's looking at you for the answer, then you can answer however you feel appropriate, but be honest, because you can be honest with them 100 times, but they will always remember that one time you weren't. So always, always, always be honest with your patients. And never tell them that, oh, well, you want to do this because you'll be cured. Because there's no guarantee. This is the best we have, and it will hopefully cure them, but, sometimes it doesn't go as planned, and you can't tell them that it's going to happen. Well, in those cases, I would think the parents would for sure step in and say something before you have a chance to, kind of thing. But when they're keeping things from the child, a lot of times the treatment team will talk to the family about these things because the child always seems to know. You can hide the fact that they're dying, you can do whatever, but the child knows. And so usually it just requires more support of the parents, and then you eventually can come to some sort of agreement on what should be told to the child. But yeah, the parents, you need to do what the parents want, but you definitely wouldn't lie to them. Does that make sense? Offer to talk, but remember to mostly listen. Never make it about yourself, ever. I hardly ever told patients that I was a cancer survivor for this reason. It wasn't about me. It was not about my situation. My situation doesn't mean anything for their situation. Like, you really need to listen to them. Allow grieving, anger, and depression. All these things would be 100% normal when you're losing a body part or having this serious of a situation. And then these prostheses, you should evaluate for revisions and refittings. So as you can imagine, you have a prosthesis for a kid who's 5. Well, guess how much they're going to grow between the time they're 5 and they're 20. They're going to need lots of different ones. And they also beat up on them quite a bit. A patient who played high school basketball on his prosthesis and needed it replaced quite often because he must have been a tough customer when it came to playing basketball. And then the other thing is phantom pain. So phantom pain is a pain that you feel that feels like it's coming from a body part that's not there anymore. So they will need to be treated with medications for a while to get rid of that feeling, because those pains actually come from the CNS system. So the CNS doesn't necessarily recognize that it's been cut off, that the leg's no longer there. So it takes a while for them. So they will feel like it's there when it's really not. And that's the time we have. I can integrity. The rest is just a few more. Oh yeah, I think so. I'm going to talk about retinoblastoma next because I know that there's a test question about this one. Retinoblastoma is an eye tumor. It is, as you can see from the word, retinoblastoma, it comes from the retina. It comes from a malignant tumor. Let's see, typically these kids are about 2 and under when they're diagnosed. It only happens about 200 cases a year, and it can be inherited. The main thing about it is that there's a cat's eye reflex. So basically what happens is, and you can see pretty well, I think, in this child, that when you take a picture of the child, usually when you shine a light in the eye, you should see a red reflex, right? Well, that is blocked by tumor. So what you're seeing here is the tumor glowing white. And they call it cat's eye because that's what cat's eye looks like, right? So once they're diagnosed, a lot of times parents will look back in pictures and be like, oh, this has been going on for a little while. Like, I can see it in some pictures. The light will catch it just right. So that is more, that's typically how it's found, is because the pediatrician should be at every well child check, checking for the red reflex. And sometimes when the red reflex isn't there, you look for things like retinoblastoma. There's a couple other things it could be, but retinoblastoma is one of the main causes of leukocoria. Also, sometimes with strabismus, when the eyes don't follow quite right, it's because of a tumor in the eye. And then blindness in that eye is a late sign. So the tumor can get so big that it causes blindness. So the treatment is typically inoculations. So they remove the eye and do chemotherapy and radiation to cure the tumor. Here's a picture of a child with leukocoria, and then here's later with a prosthetic eye. And one comment I have on this is that these eyes now are so beautiful that I seriously, on several patients, if I couldn't remember which eye it was, and I shine the light, like I have to shine a light to figure out which one it is, because the pupil obviously won't react in a prosthetic eye. It's just a piece of glass. But they're seriously so beautiful that it's hard to tell. The problem with kids, though, and they're so young, is that sometimes they'll take it out, they'll stick it in their mouth, like gross. But so retinoblastoma, although it sounds so terrible to lose an eye, they actually, because the pathways haven't, so your eyes develop until you're about 7 years old. So because these kids have their eye removed so young, they actually, as they get older, this is completely shut off, so this one works better. If you lose an eye after the age of 7, you will always have a deficit on this side. These kids, because they lose it so young, end up having just almost as good a vision as someone else because of how the pathways are then come together by the time they're 7. These kids, though, always wear glasses. And they don't even necessarily need a prescription, but you do it for protection. They only have one good eye left. You don't want anything to happen to that eye. So they wear glasses to protect that eye for the rest of their life. Testicular tumors. So in adolescents, if you find a testicular tumor in an adolescent, it's usually malignant. It's a painless testicular swelling. And this is why every adolescent male should be taught to do the testicular self-exam. Best to do after a warm bath or shower because that scrotal skin is more relaxed. And the testicle really should be firm, smooth, egg-shaped contour. This is what the kind of things that you teach when you're teaching to do kids to do testicular self-exams. I'm going to flip back a little. So Wilms tumor is also called nephroblastoma. It is a kidney tumor. Usually happens when they're really young, between 2 and 3 years old. This is one that's also sometimes inherited. Sometimes the parent will have had it too. And it's painless in the abdomen. And usually parents see it because they'll see their child naked and be like, there's a little bit of a bulge on one side, or they'll be able to see the tumor. But otherwise, they typically don't have any of the symptoms. Sometimes they'll also be detected because they'll have a little bit of blood in their urine, be anemic, or have some hypertension if it's been going on for quite a while. And the treatment is to remove the affected kidney and to do chemotherapy and maybe radiation, depending. So the kidney, I didn't have any pictures of it, but I've seen images of kidneys, on CT or whatever. And this kidney, so if a kidney is typically, fist-sized, smaller in a child, they're fist-sized, then it is like this huge mass, and it looks like just a mess in there, honestly. And that's why they take it out. They take it out because it just doesn't function anymore. They're living off their other kidney. So they take that kidney out because it literally is doing nothing. Long term for these kids, they only have one kidney, so you need to protect the one kidney. Just like you need to protect the one eye, you need to protect the one kidney. They need to avoid contact sports is the current recommendation. And also they need prompt detection and treatment of UTIs because you really don't want scarring from a UTI or anything else to happen to these kids. Neuroblastoma is not a brain tumor. It sounds like it should be from its name, but it is not. It actually develops in the sympathetic nervous system, so you can see it the sympathetic nervous system goes all around down the spinal cord. So these tumors actually show up along that line somewhere. Most of the time, half of the time, it's in the adrenal gland itself. The adrenal gland, remember, sits on top of the kidney. And it becomes the big abdominal tumor. And this is one of the ones where parents have the most regret because these tumors are similar to Wilms tumors in that they're a big mass in their abdomen, right? But these kids are sick when they come in. They have systemic symptoms. It stays silent for a really long time because there's so much space in the abdomen for it to grow. But when they do come in, they usually have a big belly like this, a big hard belly, because it's a big mass. You can see here, this is that huge mass of the neuroblastoma. So they usually have come in with abdominal pain. They've been throwing up. They have weight loss, fatigue, bone pain. They are not well appearing like those Wilms kids. And then this treatment is stage dependent, and it depends on. So kids that are 1 year old are under, those tumors actually typically regress on their own. So what you do is you just watch them. But once they're over 1, if they have a good prognosis if they have localized disease, but by the time they come in, it's usually a stage 4, and they have a 50% chance. And this chemotherapy, the regimen is so much. It's so terrible. It's really one of the worst. So they will get chemotherapy, radiation. They get 3 stem cell transplants. They get antibody therapies, MIG therapy. They absolutely throw everything at them because this is one disease where if the disease comes back, if they're able to get them in remission and the disease comes back, the cure rate is 0%. So they throw absolutely everything that they have at them to try to cure it, and it only goes well 50% of the time. It's a very unfortunate disease and diagnosis. Common in kids about 2 to 5 years old. The last one is rhabdo. Rhabdomyosarcoma develops in the skeletal muscle. So it can arise from really anywhere, any anatomic site. Most common is the head and neck, though. It's usually a painless mass. The staging is super complicated. It's definitely not something we're going to go into. You give them surgery, chemo, and radiation. And I changed this from 1 to 2 slides from 2 slides to 1 slide in the last couple of days because I'm like, we don't need to talk this much about rhabdo. So the survival rates depend on tumor size, their location, and the amount of tumor that can be removed. And I think that covered all of them then. Sorry to go over my time. I tend to do that because I love the subject so much. And I want to wish you all good luck in finding something. I hope that you find something you love, like I found something that I love.